This is quite an interesting subject, really, because acute means different things to different people, and in the field of TMD, acute is quite an interesting concept, because acute to our patients very often means it's the one that really hurts, isn't it? It's the thing that brings them in through the door, but actually what their acute presentation is may not be a truly acute condition in the true sense of the word, because if you look up acute as opposed to chronic, acute becomes chronic after it's been there for 6 months or more. TMD is also a very misused and difficult term, really. We talk about temporomandibular disorders, but that takes in a huge range, and by the end of today you're going to be a bit buzzing about all the sorts of things which really start to come in under that bracket of TMD. Of course, pain management and elimination is about the most satisfying thing we could ever do, you know. So, nociception. Nociception is the perception of pain or dysfunction, altered function. And so I think there is a big hole in the way we actually ask the questions about why a cavity has appeared in a particular place. In particular, was that there have been some more recent advances in anatomy. Now we're looking at the sensory branches. That's why pulpal pain is so exquisitely persistent, the distribution of the trigeminal nerve. And I think we have to be aware of this, and we have to be aware of the crossover. Even if we're then going to work with the ENT or other people, but there needs to be a crossover. We need to be aware of the consequences. You need to be aware and remind yourself of those sympathetic nervous system connections. An awful lot of our patients are like they don't get out. When our patients come through the door, we should be asking about all of these things.